After this lecture is going to address elbow and forearm, so take your notes and we'll fill out the first part. Joint stresses at the elbow. When we're talking about these forces, we're usually working with an overhead or throwing athlete. So when they go into an acceleration of the arm, we'll see more lateral compressive forces and medially distraction forces applied at the elbow joint. When their arm then is in deceleration, it's a really high demand on three muscles in particular: the biceps, the brachioradialis, and the brachialis. So those are oftentimes the muscles that need to be strengthened, or they get some tendonitis at the elbow as well with deceleration forces. The effects of a lot of lateral stresses, because they are compressive, will lead to more bony type issues. So osteophytes, which are like little calcium deposits within the joint, articular damage, so damage to the actual joint surfaces, or osteochondritis dissecans, which is a situation where you have a decrease of bone density or actually some necrosis or death of bone because of several different possible reasons, and they don't usually know what reason, but they say that more on the lateral elbow. Effects of the medial stresses, because they are soft tissue in nature, you'll see things like tendonitis, sprains, strains, and uritis showing up on the medial elbow. The elbow is unique in that there's a high degree of congruency within the Ulnohumeral joint, meaning that it fits together really well, so it's a really stable joint. And the muscles that transverse the joint insert actually into the capsule. So the brachialis inserts into the anterior superior joint capsule, and that can actually end up predisposing somebody to adhesion problems if they have too long of immobilization of the elbow. So we're really careful on how long the elbow is immobilized. The anterior capsule is really thin and can be damaged with aggressive stretching. So just some points to keep in mind as we look at rehab of the elbow. In regards to flexibility, we will be wanting to prevent loss of motion, loss of motion can easily take place at the elbow. So continuous passive motion machines are used early. Just passive motion is used early, and you tend to see really shortened immobilization times at the elbow. B is regaining loss of motion. We want to use short, active stretches early and more prolonged stretches later when the collagen is more mature. And in general, a long, low-load stretch is best. So your stretch times, rather than being 15 and 20 seconds, they're looking closer to a minute. Common stretches that will be done at the elbow will be going into supination to stretch the pronators, or pronation to stretch the supinators. Elbow extensors get stretched with flexion, and then some assisted flexion extension of the elbow. So lots and lots of motion to prevent flexibility. We'll go into the exercises here in a little bit, but we'll get these notes filled out. For joint mobilizations, I think we can move ahead. So here's a few stretches from the book that they suggest. Here's a way to stretch supination. So you're stretching the pronators, stretching the extensors of the elbow by bringing it into flexion. We can do supinator and pronator self-stretches, and then assisted flexion and extension. Moving on to mobilizations, the capsular pattern for the humeral ulnar joint is flexion is more limited than extension. Pronation and supination would be equally limited. We're going to use mild techniques if the elbow is really inflamed, and postpone aggressive grades until the inflammation and pain are under control. Usually they're going to start in loose packed, grades 1 and 2 being applied during those initial treatments. Loose packed position then of the ulnohumeral joint is 70 degrees of flexion and 110 degrees of supination. And we have a concave on convex joint. The radioulnar joint is the joint that allows the pronation supination, and again we're going to go into 70 degrees of flexion but with a little more supination, so 35 degrees of supination when we're working on the radioulnar joint. That too is a concave on convex joint. So our rolls and glides will be the same. Closed packed position of the elbow is full extension, and of the radioulnar joint is either full pronation or full supination, either one of those. So review the MOBs so that if you get that in the case study, you know which way to mobilize the joint. This is just distraction at the radiohumeral, which we don't always do. Ventral glides, and I'm not going to tell you what these are for. I want you to figure out the motion that this would improve. We'll review this in the case study as well. And dorsal glides. All right, moving on to strengthening of the elbow. It's going to start with isometrics, which I don't have a picture of, and then we'll progress to isotonics in a straight plane, and then into diagonal plane motions, because we rarely use our elbow in a straight plane motion, so we have to continue to do the rehab until they can do the diagonal planes, which are much more functional. So isometrics would be for elbow flexion, extension, supination, and pronation, just not letting the joint move. As far as isotonics, we have some pictures of bicep curls. You could do weights, bands, pulleys, tricep extensions, several different positions. Overhead, you could have them in supine, could have do pull downs on a cable system. Supination and pronation using a weight, like in this picture. We also, in the clinic, oftentimes would just have a hammer, and then we would add cuff weight onto it if we needed to. So those are some ideas for strengthening exercises for the elbow. Functional activities with elbow injuries, we have warming up and making sure the muscle have a cool down. They should begin overhead progressions with easy activities at shorter distances, forces, and speeds, and then gradually increase one component at a time, and no more often than every third exercise session. It becomes a little difficult if something becomes inflamed to decide and figure out which change in our program increased symptoms. And if pain is present, return to the previous level of exercise for 3 days before you progress on. All right, moving on to special rehab applications. The first one we'll talk about is the epicondylitis. Lateral epicondylitis is sometimes known as tennis elbow, and medial epicondylitis is known as golfer's elbow. The cause is cumulative trauma due to improper technique. So the treatment is going to be to find the cause, treat the inflammation with either modalities or massage. We sometimes will use what's called a counterforce brace. There's a picture of the counterforce brace to disperse the forces at the lateral epicondyle or the medial epicondyle, if that's the case. Same brace for both. We'll do some flexibility depending on what's tight, and then some strengthening of the involved tendon, progressing to eccentric strengthening of the involved tendon. Now, if you're talking lateral epicondylitis, you should just put on your notes that typically the primary muscle or the tendon that are involved is the extensor carpi radialis brevis. So the ECRB is involved primarily with lateral epicondylitis. So we'll be focusing on stretching that muscle by putting your arm into full extension, your elbow into full extension, your wrist into full flexion, and then moving into a stretch so that you're pronated. So if you extend your elbow and take a hold of your third phalange with your opposite hand, pull the wrist into flexion, and pronate the forearm. That should give a pretty good stretch of the extensor carpi radialis brevis for lateral epicondylitis. And we use the third digit to pull down on because this is attached to the base of the third metacarpal, and it will feel a more intense stretch than if you grab a different metacarpal. Make sure the equipment gets evaluated. That might be a golf club or a tennis racket or whatever, depending on their sport, to see if it's properly fitted for them, or if a racket is strung right, or a club is proper weight or length. Post-operative rehab is usually 5 to 6 months. What they do is an ECRB debridement and sometimes detachment of the flexor carpi ulnaris, and then as well as debridement and detachment of the pronator teres for a medial epicondylitis. So the one I really want you to know about, though, is the ECRB debridement for lateral epicondylitis. It's a significant surgery, and it's really fairly traumatic, so it's a last resort. Full range of motion needs to be back in 3 weeks, so we start it early. It's easy for the elbow capsule to get tight very quickly. All right, little league elbow. What causes it? Typically, it's curves and breaking pitches that increase the demand on the wrist flexors and pronators. All right. We have increased valgus stress with this slowing motion or throwing motion, which can affect the medial epicondylar growth plate. It will delay it or accelerate it. It can go either way, but it will cause inflammation then around the medial epicondyle and perhaps fragmentation of the bone off of the humerus. So typically the athlete is not well conditioned, they're not doing very many warm-ups, they're pitching too much, and trying to throw curves and breaking pitches at an age that is really too young for the number of times that they're trying to do this. Symptoms: medial elbow pain, and then they have pain when they bring their wrist into extension, and pain with resisted wrist and finger flexion. So all the flexors of the wrist are inflamed. Treatment is rest and ice, and no passive range of motion at all, just comfortable active range of motion. That's because if you do passive range of motion, you might push them too far, but usually a young pitcher is not going to push their range of motion so far that they injure things. So low weights when they're able to strengthen without pain, and an easy progression. So this condition has really decreased quite a bit since they started implementing a lot of rules in Little League about how many innings a young pitcher can pitch a week, how many pitches in a game, and then also restricting how many pitches in a practice. So here's a picture of fragmentation off of the medial epicondyle with somebody with Little League elbow. I don't have a picture for the next one, which is sprains. And typically what happens is the elbow goes into hyperextension, and there's a sprain of one of or a combination of these 4 muscles: the biceps, the brachialis, the brachioradialis, and the supinator. We can also have a medial collateral ligament sprain in the elbow, and treatment is to let it rest, let the ligaments recover, and probably doing some friction massage in a couple weeks. We're really careful with the flexor carpi ulnaris that attaches there because that may aggravate conditions of the sprains. So you treat them like you would a sprain typically of another ligament. We strengthen the muscles around the injured ligament area, and just watch the symptoms. So nothing really too involved there. Ulnar nerve damage can sometimes take place in overhead throwers, and typically it's overhead throwers with a decreased external rotation in their shoulder, so they can't get their shoulder to go into full external rotation, so they throw their elbow into a valgus position to try to get their arm back further, which then stretches this ulnar nerve across the medial elbow. Treatment is to decrease pain and inflammation with whatever modalities will work. Sometimes it's just rest. You might have to do some joint mobs at the shoulder in order to get more external rotation, and then strengthening of the shoulder for the scapula stabilizers and the shoulder external rotators. And then we also will reinforce the elbow by doing more strengthening of the elbow and the medial forearm, so the flexors. When these are recovering, though, we have to be careful that they understand that when they go into shoulder external rotation, that it does increase the valgus force at the elbow. So they might have to meet with a pitching coach or their throwing coach and start to learn a little bit different mechanics so that they don't go into forceful end range external rotation, especially if it's limited, until they're able to stretch and get more external rotation of the shoulder back. They have to be really careful. Here's a little picture of a typical ulnar nerve injury. So he goes into more of a valgus position because he doesn't have full external rotation. Dislocations of the elbow, here it's dislocated. 4 to 6 months of rehab while they're in a splint, letting these structures recover, because all these get ripped through when the humerus comes out anterior and the ulna comes posterior. We got lots of damage and scarring that takes place at the elbow. They can do work on their shoulder and wrist while they're waiting for those tissues to heal. Again, this is one where we don't do any passive range of motion, but if they do need mobs, we'll wait at least a month probably before we get going on them. Strengthening exercises are going to be focused on the elbow flexors. That capsule on the anterior side of the elbow is really thin, so they're very careful to make sure that we have good muscular reinforcement. And they need a brace, and that would be a hyperextension brace. If we're going to use one. This is, I'm going to show just a little clip of it. Here's an athlete that was at Bethel a few years ago and did posterior dislocation of the elbow. And we took him into the ER and took some films. This is what our films look like. And then they went ahead and relocated it. So I'm going to show you the video of when they relocated. I hope you can hear this. Oh, by the way, he is under quite a bit of medication right now, so he'll say some things that he wouldn't typically say. They're relocating it in the ER.
Good job, Chris. Guys.
Okay. Yeah, no, you guys are like, see ya. There's a stock in that.
Man, that is quick. Holy cow.
Yeah, I got water.
Yeah, that, holy cow. Man.
You guys want to lift that up?
Oh, it's quick. That's what on it. Yeah. Chill. I feel like I'm in Washington.
That's his soccer buddies laughing in the background.
It's good to go it in.
Okay. Already moving away more before.
Alright.
Like 2 o'clock every day right now.
2 o'clock every day? What happens at 2 o'clock every day?
Nap time.
Coach missed out.
Like not even nervous about the pain right
He's looking comfortable.
now.
It's good.
That's crazy how fast that works. I'm impressed.
I
I
can't
don't
handle
remember
this.
this, but I can't remember the moment here. But
Oh, you'll remember it. Don't have to do any crazy.
All right, so you got to see a relocation of an elbow. The last thing on your notes is arthroscopy. So that's typically done when they go in and they're removing loose bodies, little calcium deposits that will block the range of motion, and usually it will block extension. When they come out of or after that surgery and they come right to rehab, they usually need full range of motion in about 3 days, so they get going right away, and it's very achievable once that bony block is removed. So just knowing that that's possible, and you have to move quick and get the range of motion back in 3 days. All right, if you need a break, this is a good time to take it, and then come back, and the next half of this lecture is on wrist and hand. So the wrist and hand is made up of a fairly complex pulley system on the flexor side of the fingers. There's 8 pulleys that contain the flexor tendons, which is really helpful for force production, but can lead to some problems if we have an injury. So one of those problems is edema, and edema will frequently then have to accumulate in the dorsum of the hand. Finger range of motion can then be impaired, which reduces mobility and function of the hand. So the implications for the sports rehab specialist is that you need to reduce edema early. So that's very important. There's what's called a circumferential gauge, and this is used to check the edema of the fingers, very helpful. Or people, sometimes in rehab, you just simply use a piece of string and just go around circumferentially and then mark that off, and then take it over to a ruler and monitor the edema in that way. During splinting, oftentimes just a static splint is used to restrict range of motion after an injury and protect it. And the position of splinting is pretty important. So when the hand is immobilized, the wrist needs to be in slight extension. The fingers will be in slight flexion through here, and the thumb is in slight opposition. So it's a position that's very similar to if you just laid your hand down on your desk. That relaxed position that it would go to is the splinted functional position. So sometimes they use dynamic splints in order to increase motion. So it's always putting a little pressure on a particular joint and to provide a low-level stretch. Precautions with the hands and fingers is making sure that if you have a splint on them, that they don't get friction or pressure sores. The most common places would be the styloid process. That'd be on the other side of the wrist, down on that, at the base of the 5th metacarpal. The pisiform or the styloid process, I'm sorry, is here, and the pisiform on the base of the 5th, and the metatarsal heads are places that can get pressure sores if splinted. All right, so flexibility for wrist and fingers. Joint and ligament general principles are that we apply mobilization techniques before the joints are stretched. We'll stretch one joint at a time, so obviously we've got several joints here in the hand, so we just will start with one at a time. We don't curl up all the whole fingers, every joint, and then the wrist as well. We'll keep the other joints in neutral and relaxed, and the location of the stretch force is important. So we'll work from a distal portion of the arm and work more proximally. If the extrinsic muscles are tight, so those are muscles that cross the wrist, they go extrinsically, we'll start distal and move the stretches proximal. All right. If it's intrinsic tightness, meaning it's the inner ossei of the muscles within the hand that stay in the hand, we'll start with stretching the IPs, so the interphalangeal joints, and extending the MCPs. So if you put your hand in a position where you flex your IPs right here and extend your MCP, then that will stretch the intrinsic muscles of the hand. Exercises are going to be prolonged stretches, oftentimes, so there's use of night splints, continuous passive machines. There's the extrinsic finger. I just talked about that earlier. And intrinsic. So night splints, we might use some taping technique. This is pretty aggressive, just to hold them in to a long stretch with a low load. Moving on to joint mobilizations, the distal radioulnar joint. We'll be doing primarily anterior-posterior glides to improve pronation and supination, so we're talking about this joint. At the wrist, we have a convex on a concave surface. Loose pack position is in neutral, so not flexed or extended right in the middle. And then the MCPs and the IPs are concave on convex, and loose pack position is 20 degrees of flexion. So I'm not going to go over these a lot, but here's some traction. Here's the, she's doing both dorsal and volar glides on that, and radial and ulnar glides. So make sure that you review these, figure out which ones increase which motion for lab. And then anterior-posterior glides for the MCP joint. You can focus on either anterior-posterior, or you can call them dorsum palmar, to work on a particular motion, but oftentimes in the fingers they're done both directions. Okay, moving on to strengthening. The first point there says on wrist and hand, the emphasis is on the concentric activity rather than the eccentric. So that's how we have to start off with. Unless we have a tendonitis, then we will start off with concentric and then progress quickly into eccentrics. But they have to also, before we get into strengthening, make sure that they're able to extend the wrist and also flex the fingers at the same time, because they'll often be holding onto an object, and you can't hold onto an object with very good strength unless you can get into wrist extension. So we could work on, here's a picture of just wrist flexion, exercise with a weight, or extension, and then flexion, radial and ulnar deviation. We've kind of gone through some of that. This would be a really hard one, but it really works the eccentric as well for pronation and supination. There's something called Theraputty, which are good for wrist exercises. It's more elastic than like silly putty, and it stretches out, and then you can do all sorts of different grips, ulnar deviation, twisting motions, power grips, precision grips, adduction. Different colors have different resistance. So we don't have Theraputty. Sometimes I put together what I call a rubber band gym, and I'll give them different colors and thicknesses of rubber bands to progress into, but teaching them different exercises, just using a rubber band. There is something called an extensor lag in the fingers where you can passively extend the fingers, but they cannot actively get in full extension. So you can use Theraputty to have them work on extension, or a big weighted ball, and they have to just push it along using their extensors. Those are some ideas for that. Restraining exercises are when we're just working on one joint at a time. So you're just blocking the more proximal joints, the MCP and the PIP, and working on the DIP, flexion extension. General principles. Let's see, on the first A, it says a fracture is generally immobilized in a position such that the ligaments of the joint are placed on stretch in the hand in order to reduce the risk of contracture. The reason is it's most important to preserve range of motion. Very, very important, especially in the PIP. It's often stiff for months or years after an injury. We're not really sure why, but that's the joint that we see that in. Immobilization is often maintained for 2 to 3 weeks unless the fracture is unstable, displaced, or comminuted. C is, I want you to write in there ORIF, which stands for open reduction and internal fixation. That's used if there is an unstable fracture where they go in and actually put some sort of hardware in there to stabilize. Immobilization is used for only as many joints as is absolutely necessary. Again, we don't want to over immobilize in the hand. And then the last one, don't be afraid to get an x-ray if you're unsure. It's sometimes really difficult to see if somebody has a little avulsion or chip fracture. All right, with our different fractures, the 3 main ones that you see in the wrist are a Smith, Colles, or Barton fracture. Smith's fracture is this top one up here where the distal radius is fractured and displaced into the Palmar direction. That's a Smith's fracture. This is a surgical candidate. There's a lot of vascular and neurological structures on this side that have to be careful. So this needs to be stabilized fairly quick. A Colles fracture is an extension fracture of the radius, so usually falling on an outstretched arm, and the distal radius is fractured and displaced dorsally. And a Barton's fracture is a fracture and subluxation of the wrist. So it fractures either down towards the palmar surface, like a Smith's fracture, and then also subluxes, or it can go dorsally, like a Colles fracture, and this also subluxes. So 3 different kinds of fractures. Program considerations and progressions. We use Coban wrap, which is that flexible kind of wrap that doesn't stick to the skin, it just sticks to itself, and that helps with reduction of edema. Or isotoner gloves were often used in the hand rehab places that I observed when I was in school. It's because they have a pretty uniform amount of compression through the fingers and into the hand. But there's some rehab things that have to be met. So when we're working with the hand, they need to be able to, and you should do this on your own as we're talking through this, but you need to be able to flex your interphalangeals while extending your MCPs. So that has to be something that is met. You need to be able to extend your interphalangeal joints while flexing your MCP joints, and then be able to flex your interphalangeal joints at the same time as you flex your MCP, so making a fist. And we usually start with isometrics, progress into isotonics, and then into functional activities for fractures. The next one, carpal and metacarpal fractures. We could have a scaphoid fracture, which would be down here, and does not heal real well. They're often immobilized, and so there isn't a lot of rehab involved. A Bennett's fracture is a fracture of the first metacarpal, so we're going to move more distal, and we have a little fracture up there. There's something also called the reverse Bennett's, which is the same thing, only on the fifth metacarpal. Program considerations, making sure that they can move the thumb actively after this heals and they're able to start, so that they don't get restriction of the web space in there is really the primary thing. Phalangeal fractures, proximal versus middle phalanx fractures. Usually the proximal phalanx fracture can become dislocated or displaced and unstable. So sometimes these, if they're really obvious, will have to be pinned in our surgical candidates. Adhesions of the tendons are very possible and can be some complications. So hands are not mobilized very often, more than about 4 weeks at a time. The PIP joint is usually the one that dislocates if we have a dislocation. Oh, I'm not going to move. Oh, maybe I will. Here's a PIP dislocation. If they dislocate, usually it's dorsally, dorsal dislocation, and it's just a distraction and relocation. Those usually do pretty well. They should get an x-ray though. Mallet finger is an avulsion of the extensor tendon. So this avulses off and they cannot extend the DIP joint. So they're put in a splint like this. They call it a no-peak splint, meaning that you don't take it out of this position. That avulsion, that fracture piece needs to stay approximated so that it will heal, and it would really only take one flexion motion to break that up, and then you have to start your time all over again, which is usually keeping it in a splint for 6 to 8 weeks. So that one we pretty good about telling them not to cheat on that. Splinting the PIP, just make a note here that you don't splint more than 30 degrees ever, and the PIP frequently will be stiff for a long time. I think we mentioned that earlier in the lecture. The next one is dislocations I talked about, usually of the IP. A finger can be sprained if you sprain the ligaments around it. Some people will say it's a jammed finger, but really it's a spraining of the ligaments. Unstable ones will require surgical repair. And again, PIP under program considerations B, I think I have some blanks there. PIP joint can be splinted in 20 to 30 degrees of flexion for only about 1 to 2 weeks. And not more than 30 degrees, or else we get what we call a flexion contracture. It's difficult to get range of motion back. There's just a few overuse injuries are categorized as overuse injuries. Carpal tunnel syndrome. Medically, we'll put them in a splint so that they don't go into extreme flexion or extension, especially at night when they're sleeping, and that's when that nerve gets either compressed or stretched, and they lose feeling in their fingers. We might try some modalities. We might try some flexion strengthening exercises. If they do surgery, they come in and now they do a lot with laser, and they'll go through and shear or loosen or partially cut that transverse carpal ligament there. And then there's the rehab involves desensitization, so lots of hand massage, and then some soft tissue mobilization as this heals up so it doesn't scar down. Decurve veins is the other overuse injury, and the tendons involved in Decurve veins, I don't have it on there, so are these two tendons here, the abductor pollicis longus and the extensor pollicis brevis. And for Decurve veins, they're put into a splint to hold their thumb into just a neutral position. And their wrist will be a little bit extended, and then the MCP is put into 10 degrees of flexion until that inflammation goes down, and then we start some strengthening of those tendons. Because anytime there's an inflammation of the tendons, there's going to be weakening of the tendons. So Finally, on your notes, just a few principles on tendon injuries. That tendon gliding exercises are key to preventing adhesions, which essentially is passive range of motion of tendons. And then when they can do the action actively, they will as soon as possible. And tendon glides or stretches must be possible before resistance exercises can begin. And then finally, there's just a few differences between flexor and extensor tendons that I want you to be aware of. One is that the majority of the flexor tendon length is enclosed in a sheath. So you can see, here's an example of what a sheath is, this blue. And so they have this around them, around those tendons. And the extensor tendons are extrasynovial. And we saw that that's where the swelling will kind of accumulate too, is on the dorsum. Flexor tendons have a strong pulley system, extensors do not. Finger flexion is greater than extension strength, so you're able to grip something with more force than you would be able to extend into with more force. Extensor tendons are flatter and thinner than flexor tendons. Extensor tendons have less tensile strength than flexors. The loss of extensor tendon mobility will actually be more debilitating than loss of flexor tendon mobility. Okay? And partly because the loss of extensor tendon mobility more severely impacts intrinsic muscle function. So making sure that the extensor tendons are moving well. In general, you'll have just probably won't see significantly affected hand, wrist, elbow injuries in rehab. There are, it's such a complicated area that they're often referred to specialists in that area. So there's hand specialists that will do rehab and therapy for patients that have hand injuries because it is such a sensitive area and very important that you don't miss or do the wrong rehab for a week even, or it can cause some significant complications. The case study should be in your notes. It's a golfer. Make sure that you read through all that information. And I am not going to hand out slips of paper for you to prepare. So you won't know what you're getting. You're just going to come in, draw out of a hat or the box, and then answer the question right as soon as you draw. So it will just be coming up one by one and drawing a piece of paper out. So be sure you're familiar with the case study. You'll do great. And we'll see you guys in lab.